Start to our conversation, you can see that we are going to have a very interesting conversation today. My name is Francis Danso-Ajari. I am with 4GBI and also with the Bioinnovation Group, and I'm going to be sort of, I guess, hosting today. Our esteemed director, acting director, Dr. Hepsi Tego is not here today, so I am taking over. There's a big conference at Akinak City, so most of the big wigs are there. But we're here, and we're recording it so that we can share with them. All right, on that note, thank you and welcome to the 14th Bioinnovation Consortium. And we do this every month, so you can share that with other people. Typically, the Bioinnovation Center was put together by three starter groups, which is, I call it the three legs of the stool. The 4GBI, as I spoke about, a nonprofit, Northeastern University, and then as well as the Academic City. Academic City and Northeastern have been the big members in the group. So 4GBI is sort of a small member now, but now we've had a fourth member, which are the consortium members. And we have a group of about 15, 20, and it's expanding. So anybody's welcome to join. And the goal or the drive is collaboration and cooperation. We say that all the time, not competition. We don't want to steal your IP or anything like that. So please join in. We want to make sure we can share ideas, share equipment, share everything else as we move forward. So on that note, I am going to welcome you to the 14th Innovation Symposium Consortium meeting, and we're going to have a wonderful presenter. Before we go forward, normally if there are any person who's new or new to the consortium, they can have a brief introduction, and then we can move forward. So you can unmute yourself and then just a brief introduction, what group you're from, and then we can proceed. If there are no new members, then we can proceed with an introduction of the speaker and we will start talking. So I'll give you some time. Just unmute or raise your hand and then you can have a chat. Going once, like in the auction, going twice, gone. All right. Doesn't seem like it is. Some people are a little bit shy, but please, we can talk. Okay. Let me introduce our esteemed speaker today. As I said, this is a 14th, and we have with us. I've put her bio on the screen because sometimes when you're reading these bios, most people don't hear anything, so you can read for yourself. Please don't judge me on my speech. We have Dr. Nanasewa Ajimankwao. She is a distinguished emergency physician at the Accident and Emergency Center of the Kolebu Teaching Hospital in Accra, Ghana, and a fellow of the Ghana College of Physicians and Surgeons in the Faculty of Emergency Medicine. Basically, she's a bigwig, all right? She really is. She holds numerous academic qualifications, and you can see all that. A postdoc diploma, critical care from the University of Birmingham. Sorry, I can't even speak. Buckingham, I think that's the UK. She has made significant contributions to medical education and clinical research, and she currently serves as the Courtesy Clinical Assistant Professor, Department of Emergency Medicine, Global Health Division, University of Florida. Oh, wow. Very cool. You can see she's a big wig. Now, this is the other big part. In her capacity as a co-CEO of SNU Coderec Company, she's committed to furthering the organization's mission to expand equitable access to quality emergency care across Africa. Drawing upon her extensive clinical acumen and frontline experience, she's instrumental in leading SNU Coderec advancement into comprehensive digital healthcare solutions provider. Before we started the conversation, we heard a brief part about it, and I thought that was actually really good to lead into this. So, Sess, we're going to call on you to do some more afterwards because this is very interesting. Having previously served as a chief medical advisor, she now directs strategic initiatives to scale operations and implement SNU-Coderec innovative emergency logistics software using the SNU code digital addressing technology across other African nations, thereby enhancing health access and strengthening emergency care delivery throughout the continent. All right. All I'm saying is she's a big wig. Please help me, join me in welcoming Dr. Nana Ajimai Sewakwa. All right. Doctor, you are on.
Thank you so much, Francis. I'm going to go ahead and share my screen.
While the doctor is sharing, let me say one thing. I believe questions, you can put some questions in the chat. Some people are a little bit shy. You can put some questions in the chat and we can address it afterwards. And yeah, all right. So I forgot to mention that. Thank you.
Okay, so can you see my slides?
Yes.
Yes.
Okay, all right, so I'm going to start. So thank you very much for the introduction. So my name is Dr. Nana Sewakwal. So just going to go straight ahead. So we know that Africa faces several challenges in emergency care, where some countries are spending up to 600 million on emergency care services. But however, you have only 9% of sub-Saharan Africa having a formal emergency medical services. And up to 40% of health spending is lost due to improper planning and inefficiencies. So how does this translate? So this is Gion in Liberia. Looks very frustrated because he has a challenge locating the accident scene after receiving a distress call. And we know that this is a common thing we hear across board. His colleague is also not able to provide any standardized charge assessments even during transports, even as they are able to pick up the patients. Now, Africa suffers the world's highest road traffic fatality of 27.5 per 100,000 population, which is far above the global average. And because of this, it's mainly due to the fact that patients cannot be located or transported quickly. And with no standardized triage protocols and decision support tool, this causes inconsistent assessments and delayed prioritization. As an emergency physician myself and a frontline worker, I'm usually overwhelmed by the high volume of patients I see in my facility, mainly because of large inappropriate referrals. And in Ghana, 0.9 hospital beds per 1,000 people, despite WHO's recommended of 5. And with overstretched resources, this often leads to reduced quality of care. Now, this is Moses in Gushegu in the northern part of Ghana. He's only PA assistant and lacks access to online resources and any sort of clinical guidance in seeing to his patients. And without decision support tools in rural settings, misdiagnosis and even prescription errors can often lead to poor health outcomes. So, what is the solution? And this is where Snowcode Red comes in. Snowcode is a leading healthcare logistics company which aims to increase access to timely emergency care by strengthening pre-hospital systems, that is even before the patient gets to the hospital. And with the Snowcode Red technology, we provide a solution for emergency, public, and primary healthcare. So what exactly do we do? So with our product, it aims to help the clients report their emergency using the Snowcode app, where they are able to generate a digital address, 6 alphanumeric code, and which can be shared in any sort of emergency and sent to the ambulance dispatch center. Now, this enables the ambulance dispatch to be able to respond and dispatch the nearest ambulance using Snowcode Red's control board, and also to determine the closest hospitals to the patient's location or the nearest facility as per the patient. The responder is able to use the software in any smart device, so it's available smart device to provide navigation to patient location and also provide transport to the nearest and appropriate facility. Additionally, it can also be installed on drones, and this can be used to provide delivery of medical supplies anywhere. The interesting thing is that the technology also works offline, and therefore making it very useful in rural and hard-to-reach areas. This is a demonstration of how, so you have an accident scene, and person makes a call, so straight to the dispatch center, inputting the 6 alphanumeric code into the system. And for mass casualty incidents where you're not able to access the area, or you need to look at how wide the incident is, You can input it into your drone, the 6 alphanumeric code, and then the drone is able to fly straight to the scene and sort of give you an initial assessment how bad the accident or incident or the casualty, what to expect. Okay. With the patient on board, the emergency medical technicians are also able to determine the level of care the patient needs using our onboard triage tool. Additionally, there's also an AI decision support tool that can also be used by first community responders to also provide local specific first aid assistance to patients. And this context-specific AI tool was enhanced by inserting context-specific settings to help it provide local-specific supports. And this increased the satisfaction of clinicians who evaluated the models to about 80.5%. Look at that more. Now, with all this, we are able to provide an e-health post, which is battery powered, and therefore can be used in any rural or hard-to-reach areas, and enables community health responders to have access to online resources and any form of clinical guidance so that they are able to provide the highest quality of care to their patients. Now, we all know that AI, large language models, are the new thing in town. And sometimes, because these are not developed within our settings, some of the responses do not reflect local context and culture. And some people have expressed this. So with us, we're able to do different combinations of LLM with prompt engineering and then the RAG as well, generating different responses. So with the prompt engineering, put in your system message. So I'll give you an example, and then the prompts and then instructions, whether the patient has any allergies, the patient has is on any medications. All this will enable the model to provide context-specific answers. So for example, if you take any of the LLMs that are available and just put in what are the first 8 steps to giving an asthma, I may ask for, assuming it's a high-end setting, you might have a mist humidifier or take the infant to a steamy bathroom. This may not be applicable to families or patients in the rural parts of this country, for example. So when you have that inputted, that is a child in a local area, rural farm in Akobo in South Sudan, for example, it might give very basic and first aid context specific things that can be used within the community. So for example, move the infant to an area with fresh air, away from dust and irritants. So it's just modifying it so that it can be used within the setting. And using the different responses and combinations, clinicians were able to evaluate the responses the AI gave, and most were satisfied that as long as it was context specific, the first aid instructions were easy and could be used within the context. So this is, sorry, of how the AI decision support tool for community responders. So it follows the ABCD. So it asks a couple of questions. Is the patient talking? Is the patient awake and alert, breathing normally? So just following the ABCDE of emergency initial assessments, and then adding the context specific is able to give you context specific instructions or steps to take that you can use within your local setting. With our enhanced data sets and with all the data we are able to collect, SNUCODE is able to assist governments and stakeholders to visualize accessibility to healthcare facilities in countries and to help identify gaps in health infrastructure. So on your right, with a map of Africa, able to map up all the health facilities, and that actually corresponds to areas where people are living in. And then on your left, you can see that of Ghana. So facilities, health centers, pharmacies, maternity homes have all been mapped up onto the Ghana map with their locations. And those within the blue areas have accessibility within 15 minutes, and those in the red areas are not able to access anything for more than an hour. So, for example, when you take Aston North constituency in the central region, Zone A has health facilities, but no roads. So the neighborhoods is represented by the black dots. The lines are the roads, and the different colors are the various health centers. So in Zone A, for example, has a health center, but no roads. So for governments looking at how to make the maximum investment, it will be better to construct roads so that people can have easy access, faster access to the health facility. Now, if you take D, for example, D has good roads, but more than an hour from the nearest facility. And therefore, if you're looking at maximizing your resources and making impact, the best would be to build a health facility within D so that people can access, the health facility quicker. So these are supposed to help with targeted planning, optimization of resources, so that overall we can have better health outcomes. Now, with our health demographic analysis tool taken from the data that we have, we're able to stratify people to where you can have people within the various age ranges. So if you're looking for girls within 10 to 14 years or adults more than 60, all this has been mapped up. And this can be used for any public health or social intervention that you have. Well, we do have people who are companies that are doing something similar in this area. But one thing with Snoo Code Red is the fact that we pride on ourselves in the fact that it works offline, so can be used in very rural and online service, online in areas where you do not have access to internet, right? So it means to generate the code. And if you're able to give that code to the EMS on the ambulance, they're able to come directly to you. It can also be used on drones, so can be used to deliver medical supplies, blood, vaccines. As compared to other competitors like Zipline, where you need a whole infrastructure and building and people to man this can be done at a fraction of that cost. So we make data-driven healthcare decisions for an entire country, right down from the entire country all the way to a single patient. And we see that these solutions are life-saving solutions that can be used in low resource settings and help to improve efficiencies. Also to equip our EMTs so that it is not just transporting patients, but able to determine the level of care and be able to use it to provide context-specific aid to our patients. And also with our data sets, able to pinpoint gaps in community and healthcare delivery so that we can optimize the little resources that we have and make the best impact. So this is the problem that we are trying to solve. I'm sure people are thinking of what do you want to do? So thinking, who are our end users? So our end users are our population. What are the problems people are living it? And what evidence proves that your problem is wrong? And how would you pilot this? This is for students who are looking to build or practice or, bring up anything that they want to help to be able to solve real world problems. This resonates with me because I work on the other side as a clinician full time. So I see the effects of how patients come in very late, have difficult access to even the basic healthcare needs and arriving very late and making it difficult for you to even solve them. So being on this side to improve accessibility and strengthen our pre-hospital systems, then we can make sure that more people have access to high quality care. This is the team that I work with. Thank you.
Thank you. That was interesting, fast. Wow. I think I'm still stuck on the codes. I'm still stuck on the codes. Okay. Um, Any questions from the audience? I want to save some couple. I have a couple of questions, but I don't want people to go because people know I will just talk plenty. Dr. Lee, any questions?
So, Nana, thank
Dr.
you.
Lee,
This,
before you speak, actually, I should have given you the opportunity to introduce yourself earlier, but I just think I was too excited and I glossed over. So, if you don't mind.
okay. Well, I'm Lee Mikowski. I'm on the faculty at Northeastern University in Boston in the bioengineering department, and uh, and I hope a very active member of this consortium and a partner in the Bioinnovation Center at Academic City. So I am delighted with the talk, Nana. Thank you very much. Really interesting. I mean, one of the obvious issues, of course, is access. And when Francis and I and Mark Fuller had spent time visiting rural health clinics in Ghana, we would often talk to people about what they needed, and one thing they always wanted was an ambulance. And of course, an ambulance is only as good as the roads that they're going to be on, and of course, in some cases, those are problematic. But access is important, and one of the things that we've talked about is trying to get electronic access to patients. For instance, Dr. Mark Fuller has been involved in trying to develop a cell phone based stethoscope where we could record heart sounds uh, into a cell phone and immediately transfer it to specialists basically anywhere in the country to get an assessment of sort of whether or not this is a patient who needs particular help or a patient that, oh, they sound fine, or a patient where we need more information. And I wonder if your organization thinks about sort of that kind of remote access to basically evaluation of patients.
Um, yes, I think the world is moving towards a digital era, and therefore, as you mentioned in Ghana, we do not have access to all the specialists. And even if we do, the numbers, if you compare the number of cardiologists we have in Ghana, they're not even up to 100, and we have a population of 30 million. And therefore, we need to find ways to really optimize access or accessibility. So how do we ensure that even though you don't have a cardiologist within your community, you have somebody who can, transfer the heart sounds or the breath sounds, right? And can be quickly evaluated. And then, you can have answers because as a clinicians, you hear if you're listening to the chest or to the heart, the different sounds, and they mean different things, and therefore different treatment options. So it is important that if we're going to transfer something, to be able to transfer, sorry, if we are able to transfer the sounds to the experts for them to interpret it quickly, for people to have some treatment options or guidance and all that, I think it's in line. I don't think what we are doing is the only thing people are doing. I have seen I think I've seen a study on it.
Mhm.
I don't know whether it's the same thing with Fuller, but I have seen people were trying to get community health workers, get a stethoscope that can sort of interpret the heart sounds, various heart sounds, and that could help you to decide what treatments or what options are there for the patients. Yeah, so I think it's a good, um, I think it's great. This is the first time I'm hearing it, but as a clinician, it will help a lot. It will help a
Mhm.
lot. Yeah.
That's great.
And if I may add, so if Dr. Kwa, if you could go back a couple of slides to the slide where we have all the equipment with the Starlink and everything like that. The quick answer to that is yes. So the equipment we put together can also act as a platform for other people trying to innovate in the space, right? So in this image, we have a solar panel to charge a battery that will last, 24 hours. The one thing that we have a lot of in Africa is the sun. You have a Starlink, which is quite outmoded. They've gotten simpler and smaller now. And so if Dr. Fuller was able to, develop his system, he could easily just plug it in here and he has internet access. And that internet access could take him either to a really powerful computer running an AI model or to a real human being on the other side of the world. And, it's that flexible as well.
So I think I have a basic question. I think I'm still sort of trying to figure out. So is each person assigned a specific code, or is the area that has the code? That's my first question. I can walk through it.
Okay. I think we've gone down a rabbit hole here. Okay. But the code is attached to a piece of land.
Right?
Okay.
So it's the land.
Yeah.
So, okay.
Yeah.
Now, I'm driving from Accra to Kumasi, Adesu. In Samom, I get an accident. So when I make a call, how do you know where I am?
So you have this new code app on your phone, right?
Okay. So the code is on my phone. I have to download it.
Yeah.
So you should already have it on your phone, right? And so when you have an accident, you may not have internet access when you have an accident, right? You generate the code for the area, then you can make a call, and then people can know where you are. And there's a distinction. You can make, calls there's the availability of calls in way more places than there is internet access, right? So, for example, in the summer of 2024, the internet cut off around West Africa. You could still make calls, but you couldn't have internet access. So you need to get the app on your phone, right? But the way 99% of people use it is that they generate the code. It's on a sticker that they put on the fridge in the home or on the door in the office. And so that's where most emergencies happen. My grandmother doesn't even have to have a smartphone, right? She generates her code, or I generate it for her, and I stick it on her fridge. And when she has an emergency, she calls with a normal phone and says, "Hey, this is where I am." So she could use a basic YAM. She could also text it, for example, and things like that. So now everybody has an address. And with that text, we now know precisely where you are. We know where the closest pharmacy to you is. We know that there's a midwife who is, 5 minutes away. And so even if you're a 37-year-old man with a head injury, but we know that you are, 8 hours from, the closest hospital with an MRI, or a CT scan, we can say, get the midwife in. Because she's really trained to deal with pregnant women, but she has a lot of the things you need, like gauze, bandages, disinfectants, and stuff like that. So we give you the best care that is possible in your context.
I'm still stuck in the code generation part, so just work with me for a minute. So my okay, not my grandmother, me. I'm at home. So when I'm at home, the code works, yes. But now I am on the road, right? I'm traveling. So when I'm traveling, I have to generate a new code.
Another code, yeah.
Yeah.
Oh,
but that's a very minority of the cases. We've also built the system to go directly into your vehicle. So in that case, you can, with the right vehicle manufacturers, we can basically just have a panic button, and you just push that panic button, and that handles everything else. There are since the iPhone 15, right, 16 and 17, you've got satellite communication. It's very, very low bandwidth, but because you're generating a code, you can literally send a distress signal, and people know exactly and precisely where you are. But as you would already know, the emergencies that happen out in the middle of the road or whatever it is are sort of the exceptions, right? For example, 40% of something like 40% of emergency are sort of obstetrics and gynecological, right, related to childbirth. The mother is at home, you need to decide whether somebody should be coming to her or whether the road conditions are okay, right? Most emergencies happen at home or at work. So that's what we are optimizing for. But if you already have the app on your phone, you can always generate it. And yeah, it works. Even when you're in airplane mode.
One more question and I'll stop. So
Yes.
for me, it seems, I mean, getting people to do things is difficult.
Mm-hmm.
Was it considered where you put the system at the telephone end where they call and then you identify where they're calling from?
Yes. So we've actually built systems like that for an organization called LFR. But there's a lot of inconsistency with what the telcos will allow. You can understand how if somebody can remotely get your location, how that could be a security risk for them, right? So in Ghana, for example, the system works on MTN, but it doesn't work on Vodafone, right? And that's why we don't talk about it too much, because that, unless it's universal, you don't want to put it out there. So there's a technology that in a past life I used to use. I used to work for the police in London doing digital forensics. So we can do cell site triangulation. So that even works with a phone that does not a non-smartphone, right?
Right.
And so we can sort of estimate where you are based on, the signal strength between towers, right? So it's all Venn diagrams, and, the stronger the signal, the smaller the circle, and the weaker the signal, the bigger the circle, and the intersection point is probably where you are. So there are lots of really cool things that you can do that we have done. So before we talk about anything, we've actually operationalized it. But because of the different policies that different telcos have, you can't always do it. So you send for the triangulation locations from certain telcos and they do not respond. And that's for good reason, right? So that, somebody cannot track you, what's it called, maliciously. But it's possible. And in some countries, it's, I know at least in England, the police and the ambulance services have access to that. And the telcos are required by law to give access. So yeah. But sometimes it's legislation rather than the technology. But in terms of the technology, we have built it, and it's worked.
All right.
So
I will stop with my questions.
the legislation needs to keep up.
Hey, Francis, one of the things I think you're missing is that don't forget, cell phones all have GPS in them now that's much more accurate than triangulation from the cell phone towers. And that's basically, so the app just has a lookup table, looks at where you are on the GPS information and uses a lookup table to generate the code.
Oh, yeah. I mean, I don't have a problem with that. I think my issue is getting the person to do the code before they do the call. I think that's where getting people to do things can be challenging. So, but maybe in an emergency, they will do it.
So so now that I have one solution that we have is when someone calls 911, the 911 operator can send them a single link for them to click on. And if they have a smartphone, it will get their location and send it back to the 911 operator. So it's literally one button to push.
Okay.
Yeah.
Yeah. I think,
so,
I've
and
seen
that can also be sent without the internet. We've done that as well. The thing with triangulation is problematic because it's only accurate to 200 meters. And in an urban setting, somebody has a heart attack, 200-meter radius is you could be as much as 400 meters away. And the person is now able to respond. So we always want to go for GPS rather than cell site triangulation. And it's a problem that's solving itself. I do not think we will have phones that do not have GPS in 5 years' time. So it's a problem that's solving itself.
Anybody else questions?
So yeah, I have a question. I mean, you're obviously focused on the broad range of emergency medicine responses. Is there any discussion now about the potential impact of the Ebola outbreak in Eastern Congo and Uganda? I know that's a long ways away from Ghana, but is that something you worry about?
Dr. Kwok, could I take this?
Yeah, you can.
Okay. So it's funny. I came back from Uganda on Friday last week. Yeah. And we were in the country, not with SNUCode, but not with SNUCode, right, but with SNUCode, building them an addressing system. SNUCode Red's genesis was from specifically the Ebola outbreak of 2020, of 2015.
Yep.
Right.
Oh, I did. Okay.
Right. And the problem was that, in Liberia, for example, you have a patient, they have Ebola, you've tested them. Now you need to go back to where they came from, and they don't have an address, and you don't have enough, healthcare workers to be going around chasing people. And because they don't have an address, even if they found the right place, the people will just deny that, this is the address. So we were encouraged to do that. So yes, we do many things, including network analysis for roads and things like that, so we can predict if there's Ebola in one village, that the likelihood that the next case will appear in the next village, based on the connectivity of the roads and things like that. So all of this is, the technology that we're doing. And I think the background, our background coming to this is from, I used to do a lot of work for the military, and then the police. So you can call this my arc of redemption. But with the military, you have a situation where people are actively trying to make sure that you don't communicate in the theaters that you operate. And with the police, people are actively trying to make sure that you are not able to find them. The technologies that allow you to find them and operate to operate and find them respectively are, ironically, what ends up being really powerful in Africa, where the conditions are what are conspiring against you. So you now have the ability to pinpoint every house. We've literally counted every house in Africa. So there are 13.2 million houses or buildings in Ghana, for example. We know how those houses are linked to other houses. And so we know if somebody has Ebola in this house, the statistical likelihood that, any other house in the country will be the next to be infected. So all of this is now getting very computational. And that's what we do. That's the sort of thing we do. So the work that we've done primarily for logistics has ended up finding a lot of use in the healthcare space specifically.
So is your organization working with people in Uganda right now?
Well, we're working with the government, which is character building.
That is, you could be a great politician.
We're working with the government. And, we learned from the 2015 outbreak that working with healthcare institutions directly may not be the way to get the most impact. Because if you take Uganda, for example, we could go in and try to work with the healthcare system in Uganda. Then they then have the responsibility of making sure that everybody has an address so that they can, when they go to the hospital, they can give a precise address so that it makes disease surveillance a little bit easier. Or you can work with the government, with the post office specifically, so that everybody has an address. And they got the address not for disease. They got it so that they can order shoes and pizza and things like that to their houses. But when an emergency happens, they can use that same address to make the work of public health workers and people doing disease surveillance a little bit easier.
Mm-hmm.
And I think that's what we're doing at the moment.
Okay. And building character.
Yes.
Thank you. It just seems like this sort of a system would be extremely useful in a situation like that.
Yes, it is. And if you go to Uganda right now, it already works. Dr. Kwa, you were about to say something.
No, I was saying that yes, it's very useful so that you can be able to, like you're saying, map out, especially important for contact tracing, because that is how it spreads. So if you're able to map out where your household people likely able to quarantine and everything, I think this time people are trying to be more proactive to ensure that we don't go back to the times of 2020 with all the quarantine and stuff like that. So having a system like this, right, in place really help to limit transmission and improve on contact tracing.
Great, thank you.
I have a question about data. You just mentioned that you've mapped all the all the houses in Ghana, for example, or Africa. So do you have your own, well, first question is, how do you map the data? Do you have your own satellites or how do you do it? And if you don't, do you get it? Who do you get it from? And what are the challenges?
So we have various sources of data. We were lucky to win an award a couple of years ago for remote sensing. So we got access to some really powerful satellites. We've also been doing a lot of work with Imperial College London. So we work on a couple of projects with them. And so, from a series of tools, we were able to get the locations of all of these houses. So we basically took it of the whole of Africa and basically use machine learning to basically pick out and measure each of these houses. And that's, we SNU code on our side, we are basically mathematicians and engineers. So we like to geek out on things. The reason why Dr. Kwao is here is to make sure that we actually produce things that are useful to healthcare. And so, for example, we were able to measure all the houses. And from that, we are able to determine disposable income. As you will be aware, or some of you will be aware, where in Africa, the size of your house is very, very, very closely correlated to how rich you are, right? The first thing that anybody does when they get a little bit of money. But that's data point of perceived disposable income is synthetic, but it's useful, for example, in determining what interventions patients can comply with long term, for example, or that's what we think we could be wrong. And, those are the sort of things that Dr. Kwao is going to help us determine.
So,
so we don't.
You don't get any data from the government then?
No.
Okay.
No. We don't need that much character building.
Now, are they aware that you have this much data? That can they get it from you or use it? Because if you have all the stuff, that can be quite helpful. Are they mining it for anything else, or it's just it?
Working with governments is difficult. So we had all of this. We showed it. UNICEF had the program. We showed it to the statistical service, and their whole thing was, where did you get the data? You should have collected it from us. We can't trust it. Blah blah blah. Their automatic is we should be in control of it.
Yeah.
And the funny thing is, they had tried to count all the buildings in Kumasi and failed because they did not have the compute. And we had managed to count all the buildings in Ashanti region, which is one of the 16 regions in Ghana. And we had counted all the buildings in Africa. But they had really nice cars.
God.
Right. So the computer that we use to do all the work is, about $20,000, which is a lot to pay for a computer, but it's about a fifth of the cost of one of the VAs. That's one of the, the directors of the statistical service was driving. Great. So for us, it's about prioritizing the right thing so that you can get, you can do the right things. And I think our path into government sometimes is sort of convoluted. It comes with a recognition from other people. And once you get recognized by other people, the government wants to be close to you now. And so going directly to the government, in my experience, maybe I just don't have the social skills. It's not the way to go. I suspect very much that Dr. Kwao will have much better luck, but not me.
That's why she's the co-CEO. Exactly. Interesting. Okay.
I'm curious as to the financial underpinnings of this effort, because this is a huge effort. How does it get paid for?
As they say in Ghana, by the grace of God.
Are you
so Snoocode started as a sort of division of Snoocode. Snoocode Red started as a division of Snoocode. Okay. So till about 8 months ago, Snoocode Red was paid for basically as a corporate social responsibility of the mother company Snoocode. Now Snoocode Red is spinning out on its own, and so we are currently raising money. I think we've done a lot to prove that we are able to spend money very, very efficiently. So I'll give you one example of that. When we put in our AI model, we were able for $20 to improve the quality of the answers these systems were given by, about 120% from 6 to 80.5 or whatever the number was. In that same period, ChatGPT spent over OpenAI spent over $400 million. Of course, they were dealing with many other things, but the quality of their healthcare answers only went up by 15%. Now, I know it's specifically for the African context and in healthcare specifically, but, that's one example of how efficient that we can be with it. The other example I've already mentioned is, buying a computer instead of a new V8. So we are very, very efficient about it. And one of our secrets, and, we are happy to share it, is that we don't place as much emphasis on computer programmers as we do on mathematicians. And so we are able to solve problems at a fundamental level. And we are able to solve a very varied number of problems. So I don't know whether Dr. Kwao has mentioned this yet, but we are right now in the middle of a really big effort to translate all the Ghanaian languages using the Bible. Right? And so we always pick big tasks. And so we have a parallel corpus of English and Tree text. And after we train the model, by the end of it, it is able to translate between Tree and English. Right? Why is this important? Because one of the jobs that doctors and especially nurses do, nurses that we are losing quite aggressively, is they do the translation from the local people into English and vice versa, so that diagnosis can be made and treatments given and and adhered to. We want to be able to see whether we can automate that. And again, it has become a computational problem that we've made some breakthroughs on, and I think we'll be publishing a white paper soon on what we've been able to achieve.
No, these are great things to do, and I'm really impressed. But I'm still curious as to how you're going to be sustainable and how you're going to have it, where the income stream comes from. It doesn't sound like it's coming from government.
Yes, and so we really need to work on that. So I mentioned earlier that we did some work for LFR. So I'll give you some real numbers. So we made $50,000 for building a sort of white labeled version of our software for LFR. They do ambulances.
LFR, what's LFR?
Lay First Responders
Oh, okay.
International.
Great,
Yeah.
thank you.
So
I'm terrible. I'm terrible with acronyms.
Yeah.
I apologize.
Well, no. This is not you. I never actually explained it. So, and thanks for reminding me, Dr. Kwa. I wouldn't have been able to answer the question. And then, one of the things that we did, for example, was the National Health Service was going on to do vaccinations for the HPV. They had spent $300,000, 5 months preparing, and they were nowhere near, figuring it out. But with our systems at the time, in 4 hours, we were able to go and identify in every neighborhood how many 9 to 15-year-old girls there were, right? Now we've optimized the system so we can do it in seconds.
That's great.
Now, they spent $300,000 in 5 months. We need to convince them to pay us $100,000 in 3 minutes, right? And that's always hard because some of these things are so. And I'll be the first to admit that we are not very good commercially. But that is a focus for us now because I think we are producing things that are both economically valuable and for healthcare, more theory.
Yes, I mean, socially valuable. I mean, just valuable for the population. Valuable. I mean, it's what you're doing sounds great. And we share the same frustration, which is how do we actually bring in enough money to keep doing it?
Yeah, and I think there's the recognition that the work that people like Dr. Cloud is doing now and things that is always really good as far as attracting funding is concerned.
Right.
And so that's one way you can help. Things like this are also helpful. Unfortunately, this whole thing has ended up being commercial and engineering. But I think we should. But Dr. Kwa is really here to make sure that all that engineering and commercial work gets directed in a way that makes sense.
Right. Somebody has a question. I think is from Pat. Please go ahead, unmute and ask.
Yes, it's Kofi here from Path.
Yes, Kofi. Welcome.
Yeah, so this such great work, such an amazing tool you guys have put together. I'm just riding on the back of the question that I think just came from Lee regarding like how you intend to continue to move forward with this. I see this to be like a great public good, or that will be of great benefits to the population. This is one of the things that basically works everywhere for everybody. And when you have an innovation like this, it's pretty difficult to scale it up and make sure that it's being used widely. if you don't have a strong collaboration with the government. I mean, the government
Mm-hmm.
has, his own issues when it comes to efficiency and, technical skills and all of that, but they are kind of, your inevitable partner if you want
Mm-hmm.
to scale some of these things up. Just a couple of suggestions. A lot of times, we go ahead of the government, and that's where they become a bit jittery when you bring such a solution because people are just wondering, where did you emerge from? I mean, they've probably been thinking of doing something like this and have never been able to achieve it. And like you've mentioned, they spend a lot of money doing things in an inefficient way, not achieving the results. Um, so it's always good to start with them, hold hands with them, and walk them through what your thinking is, what your vision is, how this stands to benefit, the population at large. And based on experience, that's when, you get the kind of buy-in that you want. And
Mm-hmm.
I think it's a thing with governments everywhere, you know.
Mm-hmm.
Uh, Once a private person comes in with something, the first thought is you're in to make money, right? But you need to sell that idea of the public good to them.
Mm-hmm.
And it takes time. And like you're saying, it's a character building exercise. But you have to endure it. You have to endure it. And I tell you, when you get that buy-in,
Mhm.
90% of your work is done. So
Mm.
I don't know where you are when it comes to, engaging with government, the Ministry of Health. I heard you talk about the Statistical Service. I don't know where you are. I don't know how you intend to continue engaging with them. But like I said, they are your inevitable partner. And to have a tool like this, which is a public good, not being able to be scaled up or not being useful to everybody, seeing how powerful it is, um, you know, uh, it kind of reduces the value of the work you have put into it. So I just want to urge and recommend and suggest, and I'm happy as part we do a lot of these things, piloting innovations, and we've had quite a number of innovations that we've piloted that the government has taken up and scaled up, and we're still in the background, but the government is now leading with these things,
Mm-hmm.
and be happy to share some thoughts and ideas with you to see how that can be done. It's a tough exercise, but it's always worth pursuing that route for such high value innovations. Thanks, Anova.
I think Dr. Kwa should speak now.
Um, yes, because of the way the technology, you want to improve access to emergency care for everyone and not some people. The technology has to be sort of government driven or nationally driven, and therefore your partners definitely would have to be governments. We have had some engagements, but like you said, I've had a presentation with the CEO of the National Ambulance Service, who's actually an emergency physician. So we're starting on, that leg to see how we can collaborate to have the system on ambulances. But like you mentioned, it's a long walk, it's a journey. So you're not going to get the results immediately or the buy-in now. It still needs you to engage, follow up, let them know what you're capable of. There's also the tendency of people to sort of, see what you're doing and go behind you and try and, duplicate and make it even worse. Like we've had in the past. So it takes we have to do it carefully, making sure that we have the right buy-in, the people who understand exactly what we want to do and the benefits. That's most important, to understand the benefits behind it for the population. And then we can see how to move. So it's we've started a few talks, and we are hoping that it will be something positive. Yeah.
To add to that, I think we are all sort of products of our experiences, right? And not to sort of discount anything that was said by the person from Path. We try to engage with the government. We tried to engage with the government in 2016. Yeah, in 2016, and it nearly led to our total destruction. Right.
Yeah.
So they basically tried to copy us. I was beaten up at Mamprobi police station. I had to report it to the British High Commissioner. That's when we threatened to sue and all of that stuff. Our investors left us for 3 years. And so we basically nearly got obliterated. But that doesn't stop what you're saying from being true. It is true. And so what's, and lots of times dealing with the government is so toxic that, and I think Dr. Kwa was part of this thing a couple of years ago where we're doing a project for the Royal Academy of Engineering, where we ended up, being fleeced by the ethical committee. I always say they stole $500, but nobody, they asked us to pay things in dollars, and what's it called? The ethical committee stole $500. That's why, that's how I put it. Anyway, and so it's just lots of bad experiences, but we ended up doing great work in the end. That the work that we did in the was it 2014 or 2015, Dr. Kwao, for the time trials.
2015.
Yeah.
2015.
It ended up being the best work from the whole Royal Academy set. And they offered us, it became a formality to get the next tranche of funding. The first tranche of funding was 20,000, sort of to test things out. The next tranche of funding was £300,000. And the experience of our collaborators from Oxford University was so terrible. They just refused the money. They just didn't want to work with Ghanaian officials, as it were, even though the work was, ended up topping the cohort that we had. So it's, and that's why I feel like a lot of times I have to recuse myself from these conversations and have somebody with a little bit more of a balanced view, take these things up. So this has been our strategy. So far, our strategy is to scale the technology. So everything we build, we don't just build for Ghana, we build for the whole of Africa. And then we get people from all of these countries that we partner with. So I think it was for Senegal or whatever it was, LFR is our partner. So, so the people in, is it Senegal or Cameroon, do not know Snoo Red, but they have Snoo Red technology running through LFR. LFR in this particular situation has, the contacts, the patients, to get things through. So ultimately, we do not mind ending up like, I don't know, what's that? A Qualcomm, right? Where very few people know us, but we are in every product because we found ways of doing things efficiently. So we are very happy to partner. And maybe I hope I'm not speaking out of turn, but we are very happy to partner with, people like Path to get the technology disseminated. And I think, it's about recognizing your limitations and having the humility to sort of say that, look, I can do this part very well, but this other part we need to work with other people. But that's what I think. What I think matters less and less um, as we go along, because yeah, in the future, I think that's what Dr. Kwa will be dealing with.
Great. Wow, this has been fascinating. I love these conversations. I feel like I'm speaking to you guys like right in my living room or something. I really like it. I like these sort of, it's great. Now, but before we go, Dr. Kwao, is there any question that maybe you wish we had asked you, or we, get a chance to talk about something? And then what we could do, then we wrap up. Is there something else you wish to talk about, or you wish you'd been asked?
Um, I wanted to know more about your consortium and what exactly you do
Perfect.
and how you help students and entrepreneurs. Yeah.
All right. Now, as the host, I'm gonna change that right that to Dr. Lee. Dr. Lee, you are on the stand for this one. So a
I
broad view of the consortium and then how we are helping out. And yes.
Okay, well, I'm going to be brief because I will have to leave in 5 minutes.
Okay.
Uh, I mean, we started this as a conversation between Northeastern and Academic City, and realized that a lot of the Academic City uh, engineers and staff were very much in the same direction as we were, understanding that there are a lot of good ideas for how to improve healthcare delivery in West Africa, but none of them were actually getting to the people. And in order to get to the people, I think we really decided that commercialization was perhaps the only way to do it. And so, how do you commercialize the sorts of services that we just heard about today, or a cell phone based stethoscope, or whatever? You need to understand the entrepreneurial ecosystem in West Africa, which I will assure you I don't, uh, and then try to help work with teams that are willing to try and scale up to the point where you can actually make an impact. One of our big learning experiences was after COVID, when Northeastern put serious effort into getting respiratory assist devices to rural health clinics. And we bent over backwards to maybe get 20 units, 30 units out into the clinics, and realized there's 7,000 healthcare facilities in Ghana. We hadn't even scratched the surface. So we then realized we're in a situation. What we wanted to do was to uh, foster the development of a medical device industry within Ghana, because all of the devices and instruments used in healthcare facilities in Ghana are imported, and many of them are not designed to be anywhere near optimal for the conditions under which they're being used in, which means that they need to be designed and built uh, in Ghana, for West Africa. And once you start thinking about trying to foster the development of an entirely new industry, one institution isn't going to do it. And so we've started to try and bring in other institutions to act as partners in trying to move forward an effort to start fostering healthcare delivery in West Africa through the efforts that will be ongoing in West Africa. I may have got some of that right, Francis. You want to fix that?
Yes, I'll add to it. So that's exactly the big concepts of it. And then mostly the key point has always been designed in Africa for Africans, right? And so we realize that there are a lot of design ideas, there are a lot of projects out there, but again, the government doesn't get to see it. So we also started we have an expo. We are having an expo now where students drive or companies bring their projects so that the people get to see them, and then the next step, the missing element is the commercial entrepreneurship and commercialization. So that's the part that we are really building out. And then that includes getting the FDA involved or the standards boards involved so that we can get them right in from the beginning so we can push it forward. So that's the big concepts. Now, how are we doing it? The plan is to now get there are many design projects going around competitions. We pick about 3 or 4 of them, and then we are sort of helping them through the entrepreneurship process. How do we do that? And then we are also probably going to fund. Well, we still wouldn't looking for the money to do that, but fund some of these projects that we've worked on and picked, and we want to commercialize it. Again, it's very important to bring government in right at the beginning because, as we know, they got a health service, Minister of Health, they fund a lot of these things, so they must be involved so that we can make that happen. And as I think Cesar said, it is really a character building exercise because frankly, it was up to me. I'm like, push them away, just do it. But yes, if you get it done, and I actually do believe that if it is so well, like just like your project, if it's so done well, they eventually they'll have to come to the table, okay? Because it's done and everybody wants it. But yeah, I don't have the gods of money to do that yet. So, but once I do that, I make that happen because I like just build it, and then because people will just use it. This device you're talking about, the code SNU code red thing. I mean, it makes so much sense, and yeah, but because yeah, it does make sense anyway. So that's a big part about the group. Yeah, and again, collaboration is really the key. Path is a big part of it. Yeah, they're always available to speak. Mark, did you want to say something or?
I actually have one more question about when he started saying getting beat up. I'm thinking about getting intellectually beat up and wondering about intellectual property protection. It's and the reason I'm thinking in the US, they changed